Thank you everyone for joining us at the launch of the Models of Healthcare for Australians with Intellectual Disability report. I'm Ali, and I'm part of the National Centre of Excellence in Intellectual Disability Health's Learn and Lead group. I'll be the chair for today's webinar. We'll begin today with an acknowledgement of country. As a member of the Learn and Lead group, we respect the First Nations people and elders from this land. First Nations people have lived on this land for many years. Now we live, work, and play on this land together. We can learn a lot from all their stories and knowledge. We will now play a short video about the centre.
Hello and welcome to the National Centre of Excellence in Intellectual Disability Health.
We call it the Centre for short.
This centre makes sure people with intellectual disability get better health care.
At the centre, we talk to people with intellectual disability to find out what they think is important.
We talk to families and support people.
We work with health services and disability groups.
We bring information together from across Australia.
We share information about how to make good health services for people with intellectual disability.
We make sure there is health information for people with intellectual disability, families and supporters, health and disability workers.
We speak up on the big health issues and drive positive change.
There are 9 main groups in the centre. We call this the Consortium. There are also more than 50 wonderful partnering and collaborating organisations. People with intellectual disability are a big part of the centre. People with intellectual disability work at the centre.
We're excited about improving the health and well-being of people with intellectual disability. Please join us.
To find out more information, go to our website nceidh.org.au and sign up for our news.
Welcome to the centre.
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 Yay!
I would like to introduce your speakers for today's webinar. We are joined by Kitty Rose Foley, the team leader of the Health Services Development Team at the Centre. Ruth Leong, Research Assistant at the Kids Research Institute and the Centre. Dragna Prodonovich, a Research Officer at the Kids Research Institute and the Centre. Jenny Downs, Head of Child Disability at the Kids Research Institute and the Centre. Simon Cotterill, as Senior Advocate at the Council for Intellectual Disability. Susan Hunt, who's a lived experience advocate. We'll also be hearing from Ruby de Grief, who's a research assistant at the Queensland Centre of Excellence in Intellectual Disability and Autism Health, who could not join live today but has recorded some questions for the webinar. I'll pass over to Kitty to get the webinar started.
Thank you so much, Ali, and welcome everybody again to this webinar. I would like to acknowledge that I am joining today from the lands of the Bundjalung people. So as Ali said, my name is Kitty Rose Foley, and I'm the team lead of the Health Services Development Team. I'm usually based in Brisbane at the Queensland Centre of Excellence in Intellectual Disability and Autism Health. So it's my pleasure to launch and acknowledge that the report is now available. We will be putting a link to the report in this presentation at the very end, but if you would like to access it straight away, it is now available on the website. Some printed copies are also available, and there is an email address that you can email on the website to get one of those printed copies. There was a lot of people involved in the development of the report, which was led by Professor Jenny Downs and her team at the Telethon Kids Institute. Our team at the Queensland Centre also contributed to the report, along with Professor Julian Troller. I'd now like to throw to one of my colleagues, Ruby, to introduce herself via a pre-recording.
My name is Ruby. I am a research assistant at the Queensland Centre of Excellence in Intellectual Disabilities and Autism Health. I work on projects for the National Centre as well.
So, exploring models of care in intellectual disability health in Australia is one of the important pieces of work that we are undertaking in the Health Services Development Team. This work sits under the Service and Innovation and Models of Care, which you can see at the centre of this slide. So this report provides key foundational information about what we know about the effectiveness and cost effectiveness of models of care in intellectual disability health in Australia today. We are continuing work in this area. This slide also provides a bit of a snapshot of the other projects that are currently underway in the Health Services Development Team. Briefly, this includes a clinicians network, dental and oral health community of practice. We are conducting a few other literature summaries around the quality, effectiveness, and accessibility of healthcare. We're looking at health system reforms and approaches to this from across the world. And we're also looking at capacity building approaches, so trying to identify evidence-based capacity building approaches in intellectual disability health, which could be implemented here in Australia. There's a body of work around building the workforce capacity. So this is looking at perspectives on things like mandatory training or minimum training and developing a position statement around this. And we are running webinars and podcasts and developing a First Nations intellectual disability health framework. So I'm really more than happy to be contacted about any of this work. But for now, I would love to hand over to my colleague Dragana from the Kids Institute to talk a little bit more about the report that we are launching today.
And thank you, Kitty. I'm Dragana. I am with the Kids Research Institute in Perth, and I will be talking to you a little bit today about what a model of care is and some of the work that we did to put this project together. So why do we do this? Well, in order to understand how healthcare can be better and to ultimately improve it, it is important for us to first find out how services are currently being delivered and whether this works. So how did we go about attempting to answer this question is we conducted what's called a scoping review of Australian models of care for people with intellectual disability. So firstly, what is a model of care? So this is a word that's used quite variably, and it can be a little bit tricky to define. But if we keep it really quite simple, it generally means how services are delivered to a particular population. Models of care can vary and be influenced by things like local culture, by professional and societal resources, by community attitudes and stigma, and also the level of support that's available for their investment and development. So because models of care can mean different things depending on the context where they are applied, we needed to come up with a definition for the purpose of this work. And how we did this is we looked at everything that we could find that has been written about models of care, and we also looked at existing services for people with intellectual disability in Australia, just to try and get really an idea of what this means. And so we looked for common threads across different services, and this is physical health, mental health, and dental health. And we then categorized them to come up with a definition. So for the purpose of this work, a model of care is implementation, elements, and approaches of care. So what do we mean by implementation? This is who delivers care to people with intellectual disability, when and where. So, for example, is it done in a metropolitan service or in a rural-based service? Is it offered by a multidisciplinary team or a single specialist? When we say elements, we are talking about what care is delivered. So, for example, is there care coordination, meaning are clinicians within the health sector communicating to coordinate care for the patient? Is there cross-sectoral coordination? And this is communication between the health sector and other sectors that the person with intellectual disability may be connected to, like NDIS, education, or accommodation services. And finally, approaches. And this is how is care delivered to a person with intellectual disability. So is it person-centered? Are there reasonable adjustments that could be put into place to accommodate the patient better? And so how did we do this? We searched academic literature. So we looked at 4 big databases to find any research papers that looked at models of care. And we didn't just want to look at descriptions of models of care. So for the purpose of this work, we really wanted to look at evaluations as well, meaning has any research been done to tell us whether they work? We considered all types of studies if they included evaluations, and we also consulted with colleagues and experts in the field to try and make sure we don't miss anything. We looked online, so we looked at the Commonwealth Department of Health and government department websites across each Australian state and territory. We looked at health professional bodies like Royal Australian College of General Practitioners, and we looked at advocacy agencies like Down Syndrome Australia. And we searched their websites for any documents that could have evaluated a model of care. And we also talked to people with lived experience. So we met with a person with intellectual disability and their carer, and we met with a parent of a child with intellectual disability and complex needs. It was really important to us to find out their thoughts about the results and recommendations of this report and whether this is meaningful to them. And I will now pass you over to my colleague Ruth, who will talk to you about some of the results that we've found.
Thank you, Dragana. My name is Ruth. I am a research assistant here in Western Australia with the Kids Research Institute Australia. So I'm just going to very quickly go through what we actually found from our research. So we found just over 100 academic papers that describe different components of a model of care. We also found 55 Australian health services for people with intellectual disability across Australia. However, in all the papers that we could find, only 10 of the research articles gave us information of whether the service had good outcomes or not, and 5 reports that gave us some evaluative data. So some of the outcomes that we were looking out for example, for the patients, we were looking at things like whether they increased their access to services, whether it helped to reduce any of the invasive procedures that they had to go through. For clinicians, we looked at things like whether it increased their confidence in providing services. And we also were interested in looking at things like whether there were changes in service use. And by that, we meant whether it changed the frequency that people had to go to hospital and emergency departments. And of course, we also tried to look for information whether there were any cost savings because of these services. And of the 15 documents that we found that there were 6 of these recurring components that were associated with good outcomes. So I will go on to describe some of the examples that we have found from our research. And it's important for us to know that many of the models of care that have been described, they actually use lots of different components together as part of their service. So the first one is about different healthcare settings and multidisciplinary teams. And by that, we mean that, like the general population, people with intellectual disability need to access healthcare across different settings. It could mean primary care with their GP or a therapy team. It could mean in secondary care, they might be accessing a specialist intellectual disability team. Sometimes they're in the community, sometimes in outpatient hospital clinics. And of course, tertiary care when people go to hospitals. What we also found was that in many of these models of care, multidisciplinary teams were part of that service. So there were doctors, nurses, and different therapists within that team. The second thing that we found was person-centered care. Person-centered care is about making the health service and addressing the concerns that are important to the patient. So an example of person-centered care is actually involving the person in the healthcare discussions and in decision-making instead of just going straight to the supporters. It's also important in person-centered care that the healthcare professionals actually listen to the personal needs of the patient and then apply reasonable adjustments, which we will talk about a bit later, so that we can meet their healthcare needs as much as possible. The third component that was recurring was reasonable adjustments. And what this means is that health services make changes so that it is easier for a patient with intellectual disability to get good healthcare. An example of these could be making appointments when it is a quieter time, perhaps, so they don't have to be in the waiting area for as long. It could also mean that we book longer appointments, we use accessible information so that the information is a lot easier for the patient to understand. We found that there was a community specialist team when they used person-centered care and when they applied reasonable adjustments, that what they found was it resulted in more accurate prediction of the sedation that is required. And not only that, they also found that they could use less invasive sedation methods across different types of medical procedures. Another important reasonable adjustment that we found was the use of the Comprehensive Health Assessment Program, known as the CHAP. And this is a targeted annual assessment to be used in the community by GPs. We found 3 randomized control trials that when the CHAP assessment was being used, that it actually helped to improve healthcare because there was an increase in preventive healthcare. So examples of this was that the number of immunizations, such as for tetanus, increased by about 9 times, pap smears increased by about 8 times, and the detection of undiagnosed vision problems by over 6.5 times when compared to patients where the CHAP wasn't used. And this is a really similar result in other countries like Canada and the UK. When such targeted annual assessments were used, they were able to diagnose previously undiagnosed conditions earlier and also to reduce any avoidable deaths. The fourth component, capacity building, refers to when healthcare workers receive training to give better healthcare to people with intellectual disability. Capacity building also could refer to building the skills of the person with intellectual disability and their supporters when they are seeking help. But within our report, the focus primarily was on giving training to healthcare workers so that we can give better healthcare. We found that when capacity building was used, clinicians found that they had increased confidence, increased skill sets, and they also reported improved job satisfaction. There was a particular program, the Primary Care Enhancement Program, which was ran across 4 Australian states. So this program, the PCEP, it's not a direct health service. It's more a capacity building program to help enhance the skills of primary healthcare teams. We found that with this support, the primary healthcare teams, they reported increase in their knowledge of using inclusive communication strategies. they were they were more aware and better able to use intellectual disability health resources. They also reported being better able to apply reasonable adjustments in their practice. The report, though, reported that the engagement from GPs in the PCEP program is quite low. Care coordination was the fifth component that was commonly found. So care coordination means that health workers, they work together to plan and to deliver health services. We found in New South Wales there was a pediatric care coordination service. The use of this particular service helped to improve linkages between the local hospitals and their GPs. They reduced hospital day admissions by 42%, and it also reduced ED presentations by about 40% in a 6-month period. There were some substantial cost savings that were found, and it was estimated that the reduced hospital use reduced the cost by $1.2 million in the first 6 months, and another estimated $4.9 million over a 2-year period. Families reported that they had to travel less to the hospitals to get healthcare for their children, and because of this, there were less days of school and work that were missed. In Western Australia, there was a similar service as well in the tertiary pediatric hospital here. They also found similar outcomes for the patient, and also there were cost savings that were estimated to be about $2 million per year. And finally, we found cross-sectoral care coordination to be another important component within the models of care. So what this means was that the healthcare workers start working with non-healthcare services such as the NDIS, the Centrelink or Department of Education to provide a more holistic care for the patient. There was a service in Western Australia for children with rare and undiagnosed conditions. Many of these children had intellectual disability. And the positive outcomes that came from this program were that the children received more appropriate supports in the community and in schools. The services between the hospital and the local teams were better coordinated. And there was capacity building for health professionals and the wider community. Again, there were cost savings that were found, and it was estimated that for every $1 spent on this program, $4 was saved. I should also mention that under care coordination, there was another program in a Victorian adult tertiary hospital. Disability liaison officers provided care coordination services within the hospital, and that resulted in much faster discharge of patients from the emergency department to home. That's it. Yeah. And so from the findings, as mentioned before, there's really limited data at the moment of effectiveness and cost effectiveness of models of care in Australia for people with intellectual disability. In order for us to improve services, we really need to know what is working and what is not, so that we can spend the healthcare dollars more wisely. Some of the gaps that we're proposing from our findings is that there is very little information about patient-reported experiences. So that would be something important to investigate further. We know that transition phases are really vulnerable for patients. So examples might be moving from children to adult healthcare services or from adult to aged care services. There is very little data at the moment about what is working or what isn't during those transition phases. And finally, telehealth is a service that is possibly available for people with intellectual disability, but we don't know very much information about how effective it is at the moment in Australia. So these are some of the gaps we have found in our report. And now that we have listened to the information from the literature review that we have done, I'm going to hand over to Jenny and Susan so that we can hear a little bit more about what the healthcare journey is like for a young lady by the name of Olivia that Ruby will
ask a question before we go to that.
Thank you.
I have learned that a model of care is like a roadmap that helps health workers to make sure people get the right care. And so my first question is, what does a good model of care for supporting the health of people with intellectual disabilities look like to you?
That is such a wonderful question. My name is Jenny Downs. I'm from Western Australia, from the Kids Research Institute Australia. And Ruby, that is the best question. She's asked us, what does good look like? What makes something better? Does how we do things in healthcare, does that actually matter? And from our report, our answer to those questions, Ruby's question, is yes. And for many healthcare professionals, conducting good models of care, good quality with their service is a big driver for them in their delivery of day-to-day care. So Dragana presented the ingredients or the components of models of care that we were able to derive from the literature. And I will say, as a team, we will work further on that model and generate an even more comprehensive description of quality model of care for intellectual disability. And that's one of our upcoming projects. And then Ruth discussed the evidence that we have for each of those components and how systematic assessment, care coordination, multidisciplinary teams all contribute to effectively addressing the preferences and the needs of people with intellectual disability. So that's our summary of what we have seen in the literature. And so I'm now very excited, very pleased to introduce to you Susan Hunt from Western Australia, and we will talk together about what a good model of care looks like for her daughter, Olivia. I think we'll go here. Susan, would you like to introduce your daughter, Olivia?
I would, yes. So my daughter Liv is 17, soon to be 18. She is a very sassy, independent young lady with an excellent sense of humour. She loves music and swimming and going to school and the boys at school. She's perfected the eye roll to her mum. So she's absolutely nailing this teenage caper.
That is beautiful to hear that, Susan. We really can see her having fun. She's in nature. She's with people she loves and who love her. And I love that she's building lots of different relationships with her peers around her. That is beautiful to hear. So thank you. We're interested in healthcare and how healthcare works well for Olivia. And I wonder if we could just start by you summarising to us the needs she has at the moment for her healthcare and maybe indicate how they might have changed as she's been growing older.
Yeah, so Liv has a diagnosis of level 4 cerebral palsy, profound intellectual disability. She's not ambulatory. You can see she uses a wheelchair there. She is non-speaking, uses an eye gaze for communication, and is peg fed. So that's where her diagnosis lies right now. I would say over the years, her care needs have changed a little bit. When she was younger, her medical needs were a lot more intense. We were still learning about how to take care of Olivia and what her needs were. She's had lots of procedures over the years to improve her quality of life. So I would say her care needs her medical needs are quite stable, but her care needs are very high support for all activities of daily living.
And day to day, right, for keeping her healthy every day is
Absolutely. All feeding, all personal hygiene, keeping her safe as well. So just out and about in the community, her social and emotional needs, all of her therapy needs. Yeah.
No, that's a really clear picture that you've given us for that. And I'm interested, she's using eye gaze or communication devices. That's right, Susan?
Yeah, yeah.
Does she use her device when she's seeing a doctor or another healthcare professional, or is that in the home? Does that translate into her healthcare?
It can and it does. There's definitely been times where she has been able to use it to express her needs. I do find the environments aren't always necessarily set up really well for it. The eye gate takes up a lot of space. Sometimes hospital consult rooms can be quite small, and she needs a lot of processing time. So it can take sometimes up to 30 seconds for Olivia to be able to answer a question. And people don't always feel comfortable giving that kind of space to process.
That's right. And that's an important part of what Ruth was speaking about the reasonable adjustments for her to be able to be involved in her care. So understanding that is important for Olivia.
Yeah.
When her care was a lot more complex, as you said, when she was younger, and you were in one of the studies that we reviewed for our report. So we were so excited to realize that you had been in this paper, right? So that was a very positive report. There was good health and cost outcomes for the community, and it evaluated care coordination. How was that care coordination for Olivia and for yourself?
Yeah, so the program that Libby was involved in meant that we had a contact at the hospital with a specialised team. So they could link us in with the emergency department if we needed it, or with a medical professional who was right there at the time. Um, the program was invaluable. We were still learning how to take care of Olivia. She had a lot of specialists involved, and situations would arise that I didn't know how to manage, and I would take her to the GP and they wouldn't know how to manage, so we'd just get referred on to ED. So having that care coordination program meant that we were either cutting down on the number of ED visits, we were linked into the medical professionals in an appropriate time frame, not having to wait for outpatients, not waiting for a small situation to escalate and get worse. It was really reassuring for myself if I didn't know what to do. I had a professional who understood Olivia and her needs that I could call, and they could help support me make the right decisions. There was less stress on Olivia. So if we didn't have to present to ED or go to the GP and then get referred to ED, that was a massive bonus for all of us. Yeah. So it was a really beneficial program for us.
That is a big list of positives. Yeah, and I expect your whole family had benefits that they could reap from you both deriving benefits. And really, I'm hearing safety. There was safety for you, and I love hearing that you felt that. Unfortunately, that program stopped after a few years. So they did their evaluation, and for whatever reason, the funding was not available to continue with that program. And I wonder if you could just reflect on how that changed, how you were able to help Olivia to stay healthy.
Yeah. So I guess the reverse of everything, all of the benefits. Um, I think we definitely had more trips to ED. We had, and a lot of Olivia's healthcare takes place with the specialist at the hospital. So going to the GP was just not really an option. So there were more trips to the ED, less coordination between outpatient appointments and things like that. The team were taking care of coordination of outpatient appointments. So that meant more days off school, more days off work, more days dragging her big brother around as well. It's just us on when she's not feeling well, having to attend those appointments. And she has really quite high sensory needs. Hospitals can be a very, uh, big environment, lots of noises and lights and waiting. So that also then just increases distress. and increased anxiety and worry on myself because I, as a mum, just wanted to make sure that I could get my daughter the support and help in a timely manner. And I felt there was a little bit of a barrier to accessing that. It was not as easy. Yeah.
It sounds like there were just quite literally two sides of the coin. It flipped. That's a very big, a very big change. You mentioned that when she was younger, and it really was quite complex to manage her healthcare needs, that it was difficult to get advice from your GP, but that has changed over the years. And I'm just wondering if you see the GP now and other health, or maybe other healthcare professionals in the community, and what that is like for you now.
I guess what's changed is I know Livy better now as well, so I can advocate for her a little better. Having had so much support over the years from the hospital, we have all of those things set up. So we do see the GP, and I think it's really good for Livy to feel comfortable in being able to access the GP. She's linked in with a great team of allied health professionals, so speech, OT, and physio, and we have a great relationship with her pharmacist. So, yeah, they've been a great support.
That's super to hear that. So I guess now we've understand about the coordination of her care and linking to the community and how all of that coordination is of value to both of you. But reflecting back, what would your message to clinicians be? What do you want them to know and to understand so that they can make sure that healthcare works well for Olivia and for other people just like Olivia?
Yes. Looking at the patient as a whole, having that coordinated and holistic approach to Olivia's healthcare needs. I would really love for Liv to be included in making her healthcare decisions. She had a major spinal operation a couple of years ago, and she was a little upset when we couldn't work out why. And she used her eye gaze to tell us that she was itchy, so we could then support her with that. She also did ask for the car to go home. And when I said it wasn't time to go home yet, she asked for a bus or a taxi. She was very well communicating. But, on after it's a couple of points that Olivia attended, she attended we were talking about how successful her operation had been. The following day at home, she expressed to me on her device, operation like better. So it's taken a solid 24 hours to be able to communicate that, but she can understand and process and have an opinion about her healthcare as well. So, I'd really like the doctors to be able to, to be able to implement and Livy too.
Allowing her involvement and her opinions and her role in the
Yeah.
And so then there's also the next part. We have the clinicians and the therapists and other healthcare professionals who are right there with you, helping her to be healthier. What about the people who are deciding who gets the healthcare funding, the people who are managing services and the policymakers? What is your message to them so that they can make sure that we have available the best healthcare for Olivia?
Yeah. So management of Liv's needs is a big task, and her healthcare needs are one part of that, and it's still quite a very large part of that. So, burnout and care burden is real. So any way that we can support carers to access supports for people they're caring for is invaluable. And that means the things like coordinated outpatient appointments, telehealth when it's available, having, just a coordinated approach would be, fantastic.
That care coordination experience that you had was invaluable, and we have 3 bodies of, or 3 sets of papers or analyses, and just like you, they are telling us of the benefits to the child or the adult with intellectual disability, to parents, and to our system, it costs less. So they're very, very strong and powerful messages, Susan. Thank you so much.
You're welcome. Thank you.
It's lovely. So we've met Olivia, we've met Susan, and we've heard their experiences, which are so important to us taking this field further forward. So I would now like to pass over to Simon Cottrell and to pick up on how our evidence and Susan's story has resonated with many of the recommendations that we have in our report. So thank you, Simon.
Thanks so much, Jenny. And I think there's a
Yes.
a slide with the recommendations that Jenny and team have made coming out of this report. So if we can get to that slide, what I said.
I have is, what is your message to governments and professional bodies to enable the best models of care for all people with intellectual disabilities in Australia?
Over to you, Simon.
Okay, wonderful. So this is quite a busy slide. It would be even busier if it had the amount of thought and detail that Jenny and the team have put into their report in it. But building on what Susan said, and thanks so much, Susan, for sharing your and Olivia's story. In relation to general practice, that Jenny talked about the Comprehensive Health Assessment Program, the CHAP, which should be done annually for everyone with intellectual disability. At the moment, about 7% of people with intellectual disability get an annual health assessment with their GP, and we need to do something to improve that. Part of the pressure on GPs is that they have to see as many patients as possible to make a living. And we know that if they're going to provide good care to people with intellectual disability, they need time. So time to do the annual health assessment, time to do the follow-ups, time for communication. So the very first recommendation coming out of this report is that we need GPs to be properly remunerated to manage people with intellectual disability with care. So that means a funding model that supports the GP to spend enough time doing the annual health assessment to mobilise the practice team, including practice nurses and potentially others, to provide continuity of care for that person. That there has been a start. The Commonwealth has paid for the intellectual property associated with the Comprehensive Health Assessment Program. It now needs to go into GP software, and GPs need to be paid appropriately to use it. They do get an annual health assessment payment when they do deliver that, but we need more wraparound funding to support continuity of care. And if you think about whose job it is to fund general practice, it's the Commonwealth's job. So we all need to be talking to the Minister for Health and to the Commonwealth Department of Health, Disability and Aged Care, with our colleagues from the Royal Australian College of General Practice, from the College of Rural and Remote Medicine and others, to make sure that general practitioners are properly remunerated to provide quality care. So that's the first call to action. The second one is about how multidisciplinary care is delivered. So in primary care settings, general practices will tend to have a primary care nurse, but allied health professionals will be working in other private businesses. Aboriginal and Torres Strait Islander health workers will be working in Aboriginal community controlled health services. Pharmacists are in their own businesses. How are their activities all coordinated? Jenny talked about the Primary Care Enhancement Program and the role of primary health networks to try to help that activity to be supported, and that needs to go further. And again, this is a Commonwealth responsibility. So we need to be talking to the Commonwealth about how multidisciplinary care can be coordinated and properly supported and remunerated. So that's in primary care. And I would say it's particularly important for adults with intellectual disability. Many kids with intellectual disability are being looked after in the public hospital system by paediatricians, but once they turn 18, they're no longer eligible for that service. So we really need general practice and primary care to be properly funded to look after people. The second set of recommendations are about training and capacity building. So if we've talked to a lot of people with intellectual disability, to carers, family supporters, and the number one thing they have on their list is that health professionals are properly trained to communicate with people with intellectual disability, to spend the time to talk to people and listen to people directly and involve them in their care. So a lot of work has been done to develop training, not just in that communication, but also in not holding unconscious bias towards people with intellectual disability and others. So stopping the diagnostic overshadowing, valuing everyone's lives and contributions that are the same. So lots of training is available. The centre is working on a knowledge exchange hub to make sure that the best training available is available in the one spot. But we need health workers to take up that training. And if you think about it, it's not straightforward. Who employs health workers and can help make sure that they get trained properly? And how do they get their training before they become health workers? So first element is undergraduate and vocational training, and there is an intellectual disability health capability framework that the Commonwealth funded to be developed and that the centre worked on. So there's a framework for making sure that training is available at universities, but we need universities to take up that framework and implement that training to make sure that new graduates are coming out with the skills. And then we need the current workforce to be trained through continuing professional development. So in the primary care sector, GPs, allied health, people who are self-employed, they do that training through under the supervision of their professional colleges and associations. We need those colleges and associations to be making sure the training's available, but also that it's rewarded and there's enough uptake. And we've heard that there is pretty low uptake in this area. Second element is everyone working in a public hospital or in a public health system in any state and territory is employed by a state government or a local health district. We need those bodies to be saying this training's got to be done. Everyone's got to have a basic level of capability to communicate effectively and to manage people with intellectual disability, because their lives are just as important as the rest of us. And we need everyone to be able to present at a public hospital and be managed appropriately. So lots of people to talk to there. So I encourage, we have at CID have been advocating to local hospital districts to make some training mandatory and to state governments, and we need help to have that happen. Now, the third area is in measurement. So Jenny talked about these models of care, but not actually knowing enough about how cost effective they are. So we've seen the program in WA closed down. We've seen the Victorian program of disability liaison officers in hospitals be scaled back a bit. Actually, those programs are very cost effective. We need the evidence about cost effectiveness to be more widely known, and all of us to be talking to state governments and local health districts about reintroducing those programs. Equally, we need to work with the NDIA, the Department of Health, Disability and Aged Care, to talk about how the care across the spectrum, not just in the health system, but in the disability support system, in other social determinants sectors, so housing, employment, is all coordinated to make things as simple as possible for people with intellectual disability and their supporters to navigate. Those things are really important, and where they're working, we need to measure their effectiveness so that the funding can be made available. And then finally, we need those programs to be funded. So the disability liaison officers in hospital, the care coordination mechanisms that are working in the NDIA, we need them to be funded. So again, it's talking to state governments and health ministries, talking to the NDIA and the Commonwealth Department to make sure care coordination, earlier intervention, preventive health interventions are funded to reduce the burden on hospitals, to reduce the burden on people with intellectual disability having to present to these stressful settings, to reduce the burden on carers and supporters. So there's some of the things I've been talking to the Commonwealth and the states and territories and to local health districts about, and really would welcome the support of everyone on this webinar to help build on that and get some programs rebuilt, and really welcome the work that Jenny and her team have done to document the evidence that supports this work. So that's it from me. Jenny.
That's lovely. Thank you, Simon. Thank you so much, because you actually drew all of the knowledge from the review, and which is spoken so clearly by Susan, helped us to draw these into recommendations. And not just we want this, we think this needs to happen, but how we can make that happen. And there's people to talk to in government, in the health sector, in everyday clinicians and everyday parents, families, and other people with intellectual disability. We all need to understand that this is such a critical need to build the quality of healthcare, and probably at less cost. So it's an exciting time, and I thank you so much, Simon, for helping us and pitching in so strongly and keeping on pitching in, because these recommendations need to be taken to people who can help us to change, or people who can change. So thank you very, very much. And I will say one thing is that WA lost that earlier program of care coordination, and there was a gap, but they are building something else up. So it's the experience was ultimately has come back to reap benefits to the community here. So that's good news. So thank you very, very much. I think I will stop sharing, and thank you all, and we'll open to questions from the audience. So thank you very much for any questions that you might have for us.
Okay, so the first question is, what should healthcare professionals be doing based off of the findings and recommendations of the report?
What should health professionals do to take up the findings from the report? I can start if you'd like me to start. I think health professionals ought to be on the lookout for training that will build their skills, their ongoing professional education. I think even with or without training is important, but I think every health professional, every clinician in their basic training has the principles of giving patients time, talking directly to patients, finding out what matters to them, what are their preferences and their needs. And right now, immediately, clinicians can be acting in a more in their best person-centered approach that they can do. And also, even at an individual clinical level, they can talk to and make sure that others involved in the in the whole process of healthcare gets the right information to take the next step to make sure that the diagnosis is followed up after the assessment, or the care is referred to somebody else for something else, and that coordination be worked on by an individual clinician, but building their group for that particular child's person. So right now, there are practical aspects of care that are within everybody's grasp. And I wonder, Susan, would you add to that right now?
Me on there, Jenny. No, I think you pretty much covered it. I think just that, awareness of giving a little bit more space, just having a real person-centered approach. So I have noticed a real shift over the years for doctors, really taking a more person-centered approach, and speaking directly to Olivia, and she responds really well when you do. And as she should be spoken to as an individual. That's who we're there for, to take care of. So
Thank you. And that's why we're waiting for the distributed funding to manage the complexities that we need to, and we know there is evidence for. Thank you.
Okay, then the next question is for family supporters or disability workers, what should their main takeaways and actions from the report be?
Shall I guess? Okay. I was so the main takeaways are many. The main takeaways are that, and Simon mentioned this, it's equity of care for each of our patients, to disarm any feelings of stigma or anxiety about what you might be able to offer to a person. It's equal, and every patient has that equal need and requirement, even though they might be different. So I think there is a takeaway at the moment is for every clinician to be open to possibilities during their healthcare interaction with that richness of person-centered approach, and adjusting so that that person can properly engage with their healthcare. If your patients are more engaged with your healthcare, and then there's better carryover at home, so we can all be a part of supporting better trajectories over time for each person. So that is a main takeaway right now. And another main takeaway is the importance of advocacy to the decision makers at government and health service levels, and to GP levels. So and through sort of the associations as well, so that there can be a really united front on a better, more equitable way of delivering healthcare to people with intellectual disability. I hope I'm getting close.
Okay, the next question is, what strategies have you seen work to ensure that people with lived experience of disability are decision makers, not just consulted in healthcare design?
Yeah, I'm going to share this answer with you, Susan. But if I just start and I'll hand over to you, I think there's a range of communication skills that people with intellectual disability will have. There's people who can speak well with sentences and can really converse quickly and very easily with a clinician, and that needs care and management to make sure that listening is full and attentive, and that you are getting a true answer, like we do with all of our patients. But there are many, many people who have less abilities to speak in sentences, but who manage their relationships, their conversations, their communication needs with more time to answer questions. As Susan pointed out with Olivia, they might have boards with pictures or ways to communicate more complex than just yes or no, and might have communication devices. So there are a range of different ways that communication can be enhanced. And I think that that is individual, and that really takes care to say, how do I communicate with you? And for the supporter or the parent to help the clinician to support with the person with intellectual disability, not to take the communication. And I wonder, Susan, can you comment on that from Olivia's perspective?
Yeah, one of the things I've found that works really well with Liz is giving her the information in advance. So having a chat about an upcoming appointment, having a chat about what might be going on for her. If we're going to have a telehealth appointment or going to the hospital, we discuss that a few times beforehand. Social stories can also help, little short videos, little YouTubes. So giving her the opportunity to kind of orient herself to what is happening. And that's just going to mean that she's better placed to process and understand what's happening in the moment. But then perhaps even the opportunity to, like I said before, it took a whole 24 hours for her to comment on the meeting the day before. So perhaps even having a way then to be able to communicate that, because I've never been able to tell the surgeon that hey, he did a good job. So, yeah, so having that opportunity would be amazing.
Yeah, so you've talked about preparation, and then we've got a model for working together during any event or any appointment, and then being prepared with what follows up from the healthcare, whatever is needed for healthcare. So I think easy read, visual resources, video resources. I think we can do more in that regard for having different media to actually present findings back to people with intellectual disability so that they can pick up on it and keep learning after the episode of healthcare. So thank you. Thank you for that question.
I just also wanted to add, I think, and to echo what Susan said, I think we consulted with a few people when writing our report, and they did talk about the anxiety that they feel leading up to an appointment and being prepared for the appointment coming up. So that might look like getting information that they can understand what the procedure is actually going to be about. It could be a video to show them what exactly is going to happen so they can be prepared and they know what is going to happen when they turn up at the appointment. And even really, information to make it very clear to them where and when to turn up to an appointment. It helps to reduce a lot of the anxiety that they feel leading up to an appointment. Another thing, an example that came up, I guess this is an anecdotal example that I've come to know of. The sectors, when NDIS and when the health sector, when they don't work together, it was really detrimental. So there was an adult client who turned up to a tertiary hospital. He was admitted and he was not allowed. This man had complex communication needs, which means that he needed to have his supporters with him because they understood his communication. They understood how to use this device and they understood his body language, when he was in pain. And someone from the hospital would never have understood his communication without the support of his supporters. So I think that's maybe something, whilst we're trying to make information accessible to the person with intellectual disability, in some circumstances, we also need to understand how important it is that they have their supporters with them as part of their conversation. So I guess I just wanted to point out that that's also a really important support. We cannot forget that sometimes people just need to have their supporters with them so that the interaction is smooth.
Okay, the next question is, a key theme today was ensuring that we have evidence-based evaluation alongside programs. What steps need to be taken to ensure this commonly occurs?
I can start maybe hand over to you, Simon. I think evidence-based practice is a fundamental principle of how we should be delivering clinical care. We want to understand exactly what we're delivering, measure and use treatments that are effective. And also we want cost effectiveness, but we really want effectiveness right there for the individual client or patient. And it's fundamental that we use evidence-based practice in this century and going forward for all of our patients. And we have to apply that to every group in our society. And that includes all of the work we're talking about today. So I think if we use evidence-based practice, we are safer as clinicians, as practitioners, because we can draw on evidence that is demonstrated and hopefully replicated in different settings. So then we can test, does this work for this person? Does this work for another person? It might be different. There might be differences because of individual people's needs and preferences, but the evidence-based practice is our starting point. And it's a principle that every single practitioner in this country would be thinking about. So it's critically important, and we're excited to bring evidence into this national conversation. Simon?
Yeah, if I can add to that. So I had a 34-year career in the Commonwealth Public Service, and evaluation has come and gone at various stages of over that time. And I think it's really important that we demand of governments that they evaluate the programs that they're rolling out, and that those evaluations are published, so that we can all benefit from the evidence. And in this report that Jenny and team have done, they've talked about grey literature, and a lot of that has been evaluations. So some governments are doing that, and they're doing that regularly. So the Commonwealth has evaluated its primary care enhancement program. At the moment, New South Wales is evaluating its specialised intellectual disability health teams. And we have to be aware of what all the programs are and be on to governments about making sure that that evaluation happens and is published. And then I think the other part is just the ongoing research agenda. So I think there's, been an important development in the National Centre being established and funded, but the National Centre doesn't have great loads of money for research. To its credit, the Commonwealth has put, I think, $20 million through the Medical Research Future Fund specifically on intellectual disability health, and that's a kind of great gain for the sector. We've got to make sure that that money is really well used, and we learn about not just what's happening, but how to do things better into the future. So I hope that answers the question.
That's
Yeah.
gorgeous.
And the next question is, hold up. We had some questions about existing models of care. Is there an existing model of care anywhere around Australia or outside Australia we could adapt or adopt? Is there other countries that already have an effective model of healthcare for adults with intellectual disability?
How about I start on that, Jenny? And so I think Australia is actually a bit at the forefront of thinking about this and about the care of people with intellectual disability. The national roadmap that we have, I think, is really kind of world leading. So that's one thing to say. I'm sure there are some areas of good practice in some other countries that we need to learn from. But secondly, and someone has put this in the chat, we have fantastic comprehensive health services for Indigenous people in Australia. They're multidisciplinary services that people who use them feel they belong to those services and get good continuity of care. And I think that kind of model for people with intellectual disability, having a general practice that cares for them over the long term, and they don't always see the GP, it might be a nurse or it might be someone else who's helping to coordinate their care. But I think that comprehensive primary healthcare model is a great one for people with intellectual disability, and we need to get on to governments to fund that. So I talked about GP funding earlier, but
Yeah.
the sort of model that Jenny, you might want to add to that.
Yeah, just a little bit. I mean, I think there are other people around the world who are thinking like we are, and that is great because there can be intersections of ideas and we can learn from them, they can learn from us. The UK is very good at training clinicians in intellectual disability, and that is a place we can look to and learn from and bring their important practices to us so we can supplement and build what we do here. And there is a really great set of primary care guidelines for adults with intellectual disability that are Canadian. And I think they're being updated soon or now. And I think so there are things happening in the world around us. Simon's right. We have some strengths right here, and we need to build those. That's our job, to uplift those strengths and remove the patchiness. We want it everywhere, but we can also learn from other places around the world, and that's important that we do so. So thank you for that question.
Okay. The next one is next question is from a disability advocate who says they have seen so many people with lived experiences who are powerful communicators. The challenge is often not the ability to share, but whether clinicals, policymakers, and health leaders recognize and act on that value. From your perspective, how can we motivate healthcare decision makers to generally listen to and embed lived experience in shaping care models?
That's possibly a question for you, Simon, and also
Okay, why don't I start and then you can continue about care models. So, the first thing to say is all of the advocacy that the National Centre does and the Council for Intellectual Disability does, we always involve people with intellectual disability in meetings with politicians, with senior officials, and that usually has a pretty powerful impact, hearing direct from people about their stories, people who don't and shouldn't have to understand how complex the health system is. They just need some proper care. And they don't care who's funding it. They don't care who's regulating it. They just need good care, and that's incredibly powerful for politicians and senior officials. That said, some of it doesn't get through, right? Or some people are not always the financial decision maker, and the emphasis in Jenny's work on showing the cost effectiveness of these models is incredibly important because finance ministers and treasurers always, in the end, decide whether something gets funded or not. So if they're cost effective, there's a debate on productivity happening today in Canberra. But if they're cost effective, they're more productive, better care for a lower cost to the system. That's incredibly convincing. Third thing I want to say is just repetition is incredibly important. So with one state government, we have very regular meetings, each of which a person with intellectual disability tells a different story at. And that sort of relentlessness is what we've got to do. We've got to be relentless about this. But over to you, Jenny, on the
Yeah, thank you. Susan, do you want to add to that? Because you articulated how important the benefits for you personally, your family, your work, ability to work, ability to less cost, less going into the hospital. Do you want to add to that? Because that comes down to that the bottom line for the government is paying the bill.
Yeah, I was just nodding along because everything just resonates. Yeah, I think I just know from our own personal experience, a number of times we've either had to go to a GP and waste our time and money and resources there, and then head into the hospital. There were so many other ways that if we would have access to the supports a different way. We don't want to be showing up more than we need to, but we do need to get the care we need when we need it. So, yeah.
Yeah, thank you. So, Susan, do you want to add to that? Because that comes down to that the bottom line for the government is paying the bill.
Yeah, I think I think I just know from our own personal experience, a number of times we've either had to go to a GP and waste our time and money and resources there, and then head into the hospital. There were so many other ways that if we would have access to the supports a different way. We don't want to be showing up more than we need to, but we do need to get the care we need when we need it. So, yeah.
That's perfect. And we need to assess that on an ongoing process, an ongoing way, so that again, we have the evidence this should be maintained or this can be improved. Let's test it this way and get better care and maybe better cost savings. And just like Simon said, the task is ongoing and we need to be persistent and relentless in always bringing the needs and the strategies to support those needs to the forefront of policymakers' minds. And hopefully we can keep going with that right now. So thank you. I think that might be the last question, Ali. Is that right?
Yes, yeah.
Okay, I'm going to share my slides because Kitty, if you can take the next steps to the audience. Thank you. We've done that. Next steps. Over to Kitty.
Okay, wonderful. Thank you so much to all the presenters and all the questions and engagement today. As I said, the next steps is absolutely to download the report so that I think you can go straight to the website to get a link to the report, or we may also show a link in a moment. Subscribe to the National Centre Health, if you haven't already, the newsletter, and please stay on Zoom afterwards to complete the post-webinar survey.
So, okay.
You're over to you, Ali.
Yeah, thank you. Thank you everyone for joining us for today's webinar. In a moment, Jenny will tell you how you can download the report. But please make sure you visit the Centre's website and subscribe to the newsletter. Please also stay on Zoom once we close the webinar to do a short survey. I will now pass over to Jenny to launch the report.
Okay, thank you. We've had a great hour and a half telling you about the work, telling you about the centre, this particular component of the work in the centre. And now there is a report of this work that you can download if you go to our website /news/Australian Models Healthcare People Intellectual Disability Scoping Review. That's us. We have you recognise the photo. Once you've seen it, you will know that is a lovely mother and her son here in WA, and they're excited that they're on our report as well. So the lived experience is infused with the report, and we hope you enjoy reading it. So thank you. If you wanted a printed copy, you can email us on that email address. We will have some printed copies. So please email if that is what you would like. So thank you. Thank you.